following is a production of West Virginia Public Broadcasting.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University. Welcome to Doctors on Call. Tonight's topic, stroke. Two experts are here to answer your questions. Now here's your host, Dr. Joe Prudhomme.
Good evening. A stroke is a brain attack. It strikes suddenly, often without warning. In a stroke, vital supplies of blood and oxygen to the brain are cut off, either by blocked or ruptured arteries. Are you at risk for a stroke? What are the symptoms? How can surgery, medication, and rehabilitation help people recover? We'll get the answers to those questions and more tonight from our two guests, Dr. Todd Krockow, Chair of Emergency Medicine at West Virginia University, and Dr. John Brick, Chair of Neurology at WVU. If you'd like to ask our guests a question, give us a call. Our phone lines are open now. John, one of the things that I don't know, and many people probably don't know, is what a stroke looks like. How can you recognize if you're having a stroke?
Strokes are typically acute events. They come on suddenly, and the patient more often than not will have weakness or numbness or on one side of the body, maybe some difficulty with speech, difficulty walking, what we call focal deficits, and that means there's a particular area of the brain that's not functioning properly and it comes on suddenly.
So if you experience that, what should you do?
The most important thing to do is go to your local emergency department. Call 911 and go now. Don't wait around. Don't say, oh, it's going to get better. I'll shake it off. That's always the wrong thing to do. Go to your local emergency department and get checked out, because the things that we can do to limit the size of the amount of brain damage have a very finite, a very brief period of time in which they're successful. And it's so very important. Go to your local emergency department, call 911 instantly and go.
Okay, so I don't go to bed and do it in the morning. I go right now, and I'm going to bump into Dr. Krockow. Todd, what do you do? You're on the front line. If I come in the emergency room and you suspect I might be having a stroke, what's going to happen to me?
So one of the first things that we're going to do when a patient comes into the emergency department is we're going to do a thorough examination. We're going to find out what are their neurologic symptoms and how severe are their deficits. Simultaneously, though, we're going to prepare the patient to go over and get a CAT scan of their brain. The CAT scan really allows us to discern which of a couple different types of stroke that we're looking at. And the third thing that we're doing, all at the same time that the first two are occurring, is to really try to nail down when was the last time this individual was in their normal neurologic, their normal functioning state. Because as John alluded to already, the single biggest factor that we're racing against is time. It's all about time.
And that's an interesting thing to me. I know that if my mom or dad were to have chest pain and act like they were having a heart attack, I'm supposed to give them an aspirin while we're on the way to the hospital. Mm-hmm. Is that a good idea with a stroke patient too?
Aspirin's also a good idea in the stroke patient as well. And early activation, early recognition of symptoms is important. A lot of Americans, a lot of folks in our country understand the signs and symptoms of heart attacks. They understand that if you're having chest pain, get sweaty, nauseated, that you should seek immediate help. Pain is a powerful motivator to seek help. Unfortunately, most strokes don't have any associated pain. So it's really important for people to understand the signs and symptoms of stroke and not delay seeking care.
This delay sounds like a big problem, and I know as we get older, a lot of things don't work right. And I know a lot of older friends of mine might have a tendency to want to go try and take a nap and see if it'll go away. How long do you have before you start killing brain cells?
Well, the brain cells, once the arterial blood supply to an area of the brain is blocked, death of brain cells occurs within minutes. But there's always an area around the edge the damaged tissue that we can save, that we can very often save with these so-called clot-busting drugs. The National Institutes of Health says that only 15% of patients who might benefit from these clot-busting drugs receive them, and the number one cause is they don't go to the emergency department fast enough.
Fast enough. Well, this is a perfect segue to our first caller. We have Virginia from Belmont County, Ohio, who thinks she may have somebody who has these types of symptoms. Virginia, please ask us your question.
Yes, thank you. My daughter passed out last year and was in the hospital 5 days. They couldn't find out why. Her pressure kept dropping, but now in March this March she started having symptoms of like she was moving and not moving. Even when she wasn't moving, she felt that sensation, and maybe like going sideways even. Now, they did find 100% blockage in one of the arteries in her neck and about 35 or 40 in the other one. But we're waiting. She's to get 3 more MRIs, and they've done everything to try to find the cause of this. She's 56 years old, and we're beside ourselves with worry.
Dr. Brick, any other questions you might have for the caller before we let her go?
Just a little clarification. Were there any other symptoms associated with this besides the sensation of movement, and how long does the sensation last?
It seems like it's going on all the time here lately. And her other symptoms, she tires so easy. She couldn't hardly stay at work. She would have to leave work. Now she's not working at this time.
Okay. It sounds as though you're describing vertigo, which is a sensation of movement, and it's a sort of a non-specific symptom. There's a lot of things that can cause vertigo. Certainly problems with the inner ear is a very common cause of vertigo, but occasionally we see patients who have vertigo and it's related to ischemia of the brain, what we call a transient ischemic attack or even a stroke. But usually there's other symptoms associated with that, such as double vision, weakness on one side of the face, some difficulty with speech. I'd have to get a little bit more information such as that, but more often than not, vertigo by itself is not a strong predictor of a stroke.
Okay, so it doesn't sound like it's probably a stroke. Virginia, good luck and keep pursuing that. It sounds like a problem that we hope you can get to the bottom of quickly. So Todd, tell me about these clot-busting drugs. If I'm going to take one of them, is it very risky?
Okay, so the clot-busting drugs have risks and benefits, just like many things that we do in medicine. And what we know is that the benefits of these clot-busting drugs are the greatest the sooner you get them. As time goes on, the benefits of these clot-busting agents diminishes over time. There is a risk associated with it, and that is these clot-busting medications can actually cause some bleeding into the brain. And statistically speaking, that will happen about 6.5% of the time. But when these clot-busting agents are used, there are a set of very strict guidelines. And those guidelines are carefully adhered to, and when used appropriately, patients who receive these clot-busting drugs have about a 30% chance of leaving the hospital neurologically normal or almost normal. And that's a profound impact.
Right. And that leads me to understand, so basically you've converted at that point the ischemic stroke into the same kind of symptoms that you would get with the other kind of stroke, the kind we haven't talked about thus far, the bleeding stroke, right?
That's correct.
Tell us about the difference between those two.
Sure. So the ischemic stroke, or those strokes in which there's a clot in the brain that blocks the downward flow of blood and oxygen to the brain cells, accounts for about 80 to 85% of all strokes. The remainder types of strokes are what we call hemorrhagic, and those are the types of strokes where there's abnormal bleeding into the brain. In some instances, people who have the abnormal bleeding will actually develop pain with their symptoms, sudden onset of the worst headache of their life, for example. Unfortunately, As I mentioned, the majority of strokes are the clot in the blood vessels, and they're not associated with pain. On a clinical basis, just looking at a patient, doing an examination, there's no reliable way to distinguish between the ischemic and hemorrhagic, and that's the reason we try to get patients to the CT scanner as quickly as we can.
But the patient might know themselves because the bleeding stroke has the bad headache associated with it, and the ischemic stroke has the other symptoms that John was telling us about. That you had an acronym for it, was FAST, wasn't it?
FAST. And this is something that is easy to remember and that people can just think about when they're considering whether or not they or one of their friends, family members, etc., may be having a stroke. The acronym stands for FACE, any facial droop, arm weakness, or weakness of the arm or leg. The S stands for slurred speech, and again, that T is in there to reiterate the importance of time. Time. The sooner you can get into an emergency department and seek evaluation, the better your chances for a full recovery.
Okay. We have somebody else, another call, who wants to ask the question. Basil from Summers County, please ask us your question.
Yes, sir. I'm a 56-year-old male, and I recently had a stroke back in January. And my symptoms started sore as a stomach virus, really. It probably lasted maybe 16 to 18 hours before the stroke actually hit me. And the stroke left me, it interfered with my eyes that I cannot see properly out of both eyes. I can see out of one eye at a time just fine. But my question actually is, I keep having symptoms of numbness in the right side of my face that radiates into my tongue and down into my arm and fingers. And we know first that both sides of my neck is 50% blocked. And I have a upcoming scheduled in Charleston to take another look at my neck. And I was wondering if doing surgery on my neck and cleaning those arteries out would alleviate those symptoms.
Okay. Well, Basil, I sure am sorry about your stroke. John, what's the chance that will help his symptoms?
It sounds like the type of symptoms you're having is related to a stroke in your brainstem, with the double vision, the epigastric upset, and that is supplied by actually different blood vessels than the carotid arteries in the front of the neck. I suspect that this was what we call a posterior circulation infarct. Now, that doesn't mean it's not serious. If you are continuing to have intermittent numbness, that needs to be evaluated, because you still may have some ongoing ischemia there, and you need to check up with your doctors in Charleston. But I suspect that the symptoms you're having are not related to your carotid arteries, but rather related to the vertebral basilar system, which is a blood vessel system in the back of your head that supplies about 20% of the blood to your brain. But this area of the brain is not usually supplied by the carotid arteries.
All right, that's very interesting. We have James on the line next from Raleigh County. James, what's your question for our panel?
Yes, so there's apparently a newly identified condition known as CCSVI, chronic cerebrospinal venous insufficiency, and it's impaired venous drainage from the brain, not inflow but outflow, and it causes some different symptoms: fatigue, tinnitus, some headache symptoms. But what do you know about CCSVI? Very new. Apparently 47 countries, or phlebologists from 47 countries, have identified this as a new condition over the past year, and they think it's very interesting to look into. It's microvascular stroke, apparently.
Okay, this sounds like another good question for John. And also tell us what, he mentioned a doctor word, tinnitus. Tell people what that is.
Tinnitus is a fancy word for ringing of the ears. That syndrome, as I'm familiar with, has been described as being possibly related to multiple sclerosis. There was a study done out of the country physician, I believe it was Italy, had a number of patients with multiple sclerosis, and he thought he identified this as a cause for multiple sclerosis. This is not within the mainstream of what we think the pathogenesis of multiple sclerosis is. And he did some procedures on these patients that he thought would open up the venous outflow out of the brain. These results have not been able to be duplicated in this country. There were some studies done at Stanford out of Palo Alto in California, and there were some bad results from this. And the American Academy of Neurology now suggests that we don't undergo those types of procedures until there is a big national clinical trial to look at that.
All right. Well, good luck with that, James, but it sounds like you need to be a little bit careful volunteering to do a treatment for this at this point. You don't want to be a guinea pig on something that's not fully figured out yet. Next call we have is from Shelby in Jackson County. Shelby, what's your question for us tonight?
Yes, I have had a stroke several years ago on my left side. It's caused a lot of weakness. And in last week, I had another spell on the right side, and they said it was a TIA. I have blockage on both sides, artery blockage on both sides of my neck. I take a lot of dizziness. I get real weak, real tired. And I'm just wondering if there's some kind of blockage maybe in the skull or in the head somewhere that doctors hasn't found. Like I said, I stay real tired all the time. I'm on about 16, 18 kinds of medicine, and I'm just looking for some answers.
Well, Shelby, I'm sorry about your situation. It sounds pretty complicated. John, are there any more diagnostic studies that might be able to answer her question that would be helpful?
Well, when you have a stroke, it's very, very important, as Todd mentioned, to carry out whatever acute interventions that are possible to try to limit the size of the stroke. But then after that, you need to have a workup to try to determine what was the cause of the stroke. And this workup can be very involved. And we want to do things like modify risk factors like hypertension, high cholesterol, check out your heart and see if there's a potential source that blood clots could be breaking loose from your heart and going up into your head. We call those emboli. Every patient that has a stroke, I believe, needs to have that type of workup because that will allow us to do whatever we can to prevent them from having additional strokes. And sometimes it means there's a blockage in the blood vessels in the neck, and that's what's caused the strokes. But there's a lot of things that can cause strokes besides blockages. And we see patients very frequently, they've had a stroke and they have a moderate degree of blockage there. And atherosclerosis, hardening the arteries, is real common. And just because there's a blockage there, that doesn't mean that blockage is what caused the stroke. And that's why every patient needs to have a very thorough workup and evaluation to determine what caused their symptoms and problems.
Now, Todd, I know that with heart attacks, they say now a lot of times it's an artery that's not even narrowed that starts the plaque. You rupture a cholesterol plaque in an artery that's not even narrowed, and that's the genesis of the clot, and that makes the heart attack. Is that true with strokes too, that you don't even have to have a narrowing of your artery, you just have a cholesterol plaque that ruptures in a wide open artery and causes?
It's true. It can in fact happen that way, and this is actually something that we've kind of discovered just within the last 10 to 15 years. We used to think that it was just simple plumbing, that as there was collection of plaque material in the vessel, increasingly getting thicker and thicker, that you would reach a critical point where the blood flow just couldn't get by there anymore. We now have understood that there are these plaques in the blood vessels, and they can be calcified and very organized, in which case they don't pose as much of a problem to many patients. And there are those plaques that can be soft and they can rupture and travel downstream and end up blocking a blood vessel and creating a problem for the brain or the heart or any other organ for that matter. So yes, the plaque concept is something that applies in the setting of stroke.
I'm going to add to one other. We see patients who have acute arterial wall injuries, a dissection of the blood vessel. And years ago when I was a resident and I was younger, we almost never saw that.
Okay.
We saw it, we didn't recognize it. The technology did not allow us to find those patients. But that is a fairly common cause for stroke now. And the treatment for that is entirely different than the typical stroke that might be caused by an atherosclerotic blockage. So it's really, really important to get a good, thorough workup in every patient.
So most of these are caused by little teeny flecks of stuff breaking off of the plaques in the carotid arteries and traveling up to a tiny little pencil-thin artery in your brain, not by the fact that the carotid artery is too narrow and there's just not getting enough blood through.
Yeah, it's artery-to-artery embolism. It's not from a hemodynamically significant stenosis. Both can cause a stroke, but usually it's artery-to-artery embolism. That's right.
It's a little flex of stuff. So I had no idea what the magnitude of this problem was when we were talking about it before the show. I was astonished when you told us how many people at WU we saw each year with potentially having a stroke and how many we admitted. Can you share that with the audience?
Yeah, we see about 5 patients a day that we're screening for stroke. Stroke is a big issue. It is the 3rd leading cause of death in the United States, and it is the leading cause of adult disability. There's about 700 to 750,000 strokes that occur in the United States each year. You do the math there, and that's one American having a stroke just about every 56 seconds. Whoa. And as John has alluded to already, atherosclerosis, the thickening of the blood vessels, is a consideration. People need to know what risk factors they have for stroke, whether it's diabetes or high blood pressure, smoking, age and gender. The over 65 crowd tends to have the bulk of strokes, but a quarter of all strokes occur in people less than 65 years of age. Race has an influence. The African American population is about twice as likely to have a stroke, and family history is important to know. So if a person has risk factors, they should be cognizant of what those risk factors are. They can often neutralize some of those risk factors, or at least address those risk factors, but they really need to be aware of the signs and symptoms of stroke should it occur to them.
Is high cholesterol one too? You made a really good list.
High cholesterol is also one of those.
You actually mentioned, John, the number of stroke patients that we admit at WU each year. What is that?
About 800 or 900 a year.
In our small hospital. And how many more come to the ER that we think might have a stroke that we say you don't have a stroke when we send home?
We have an acute stroke team at our place. So if you come to our place and either you call and you say beforehand, I'm having a stroke, or if the emergency room physician sees you or the nurse triage sees you and they decide that's what you're having a stroke, or they think that's the problem, they'll call what we call a stroke page. And then all the bells go off and everything starts to happen at the same time, like Todd mentioned. And our records are that we're right about 60% of the time. But about 40% of the time when patients come to the ER, to the emergency department, and they're having symptoms that sort of sound like it might be a stroke, after we thoroughly evaluate them, it turns out to be something else. But that's okay. We don't want to miss them. We want to find them. And so we put them through the workup to sort it out, and we'll accept that 40% number of sort of false alarms. That's okay.
Well, that doesn't sound like a high number at all, though. I mean, that's really, so if I come in the middle of the night because I think I might be having a stroke, there's a greater than 50% chance that if I have those symptoms that I really am having a stroke.
Absolutely. That's what the data shows.
That's impressive. So if I have those symptoms, the things, just do those again for everybody. We just got a minute or two left here.
Any facial droop, any arm or leg weakness, any slurred speech, and remember the importance of time. The sooner you can get in, the more likely you are to be treatable.
And every minute counts. Permanent brain damage after as little as 2 or 3 minutes even?
Yes.
So every minute counts. And then for the bleeding stroke, the worst headache of your life is the most common symptom, right?
Well, it's one of the symptoms.
Okay.
Some people can have such severe hemorrhages that they'll pass out, and they'll rely upon their friends, family members, caregivers, etc., in order to contact 911 and get help. But severe worst headache of life is one presenting symptom of that type of stroke.
Now, we mentioned taking the aspirin if you think you're having the fast symptoms. Do you want to take an aspirin if you're having this worse headache, or is that one where you might want to skip the aspirin?
So the aspirin issue, aspirin affects platelets, and you would think that theoretically the aspirin in the setting of a hemorrhagic stroke could be a bad thing. But unless John is aware, I don't know of any studies that have actually shown beyond reasonable doubt that an aspirin, there's other drugs that clearly you would not want to give in the setting of a hemorrhagic stroke. But aspirin has never been, to my knowledge, definitively proven to be in that bucket unless...
Good. Yeah. So that's all good advice tonight, folks. Remember fast. If you think you're having a stroke, take an aspirin. We've been talking about strokes tonight with Dr. Todd Crocco and Dr. John Brick. Thank you both for being with us tonight. If you'd like more information, talk to your family doctor or visit our website at wvuhealth.com. For Doctors on Call, I'm Dr. Joe Prudhomme. Good night and good health.
Join us again next week for another edition of Doctors on Call. Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
This has been a production of West Virginia Public Broadcasting.